And I really do have more slides than time permits. So what I'll be doing is trying to fly over the top to give you sort of a concept. You'll need to do your own coming back and reading later. So I'm framing this around a little boy. He came in, he was 4 years, 3 months old. He already had reflux disease. He was on Somac and Mylanta. He was totally dependent on them. Anytime they tried to remove it, he was in severe pain and reflux. He had recurrent ear infections, throat infections, recurrent gastro. Beautiful. Okay, chronic constipation, and he was Osmolax dependent. They could not stop it or he would seize up for a week at a time. Mouth ulcers and quite severe behavioural dysfunction, severe mood swings. He was oppositional, he had violence, and he had vocal tics. So this is what came in. What's his story? Before birth, his mum had pneumonia, needing antibiotics, lots of paracetamol, and she had a rib injury from coughing. She had gestational diabetes and hypertension, so there was a stressed intrauterine life before he even started. Labour, he was induced early because he was large for dates. It was a traumatic delivery and he was given IV antibiotics. So already before he's even started things, he's had a couple of rounds of antibiotics. He was exclusively breastfed, thank goodness. He had low-grade fevers for a few days, low blood sugars. He was irritable, unsettled. He screamed continually and already from the point of birth was regurgitating and it was audible. He had a rattly chest so that by 3 weeks he was put on low sec. Now, I need to just stop here and you need to all realise that there is no clinical testing or proof for the use of proton pump inhibitors in infants and small children, and yet we're doing it all the time. It's what's called off-label prescribing. Frequent Mylanta. Mylanta's high in aluminium. He then went on, when they started solids, he developed eczema. They treated him with probiotics and some dairy restriction on behalf of mum, and that helped a bit. Had diarrhoea when fruits came in, and then after his 6-month vaccination, his eczema flared badly, it became infected, and his reflux got worse. So his low sec was increased. Now we're coming into close to adult dosing happening here now. By 10 months on skin prick test, he was shown to have allergies. By 12 months, multiple food reactions. Recurrent infections from 18 months, lots of infections, ear infections, gastro, more than 18 doses of antibiotics within 12 months. This is a real child. This is not a make-up case. Chronic recurrent tonsillitis, almost continual antibiotics. By 18 months, they discovered that he had a tongue tie, a lip and a tongue tie, so that was resected. Because he was a bit bigger by then, they needed to do that under a general. It couldn't just be done with a little snip like you might with a bubby. And he reacted adversely to the general. So for the 4 hours after, he was distressed, disoriented, nobody home, screaming wild. And from then on, had ongoing, frequent, prolonged tantrums where he'd scream, throw himself backwards, couldn't be distracted, and mum said it was like nobody was home. From 2, he was getting night terrors every night. He would frequently get up night walking. He had difficulty falling asleep, and he would have these episodes where he'd be staring up at the ceiling and saying, "Can you see the lady up there?" Which, of course, mum couldn't. He was hysterical. Similar sort of age, he was noted to have delayed expressive language. His receptive language was excellent. This is one of these split things that we can often see. He was crazy, hyperactive, he was like a pinball, there was no attention span. OT assessed and said sensory overload and sensory seeking. He had ongoing reflux, and so the low sec wasn't working, so they changed him to Somac. Ongoing feeding difficulties. He couldn't cope with lumps or textures, he wouldn't chew or eat meat. Struggled to swallow. And so on speech therapy, they said he had immature chewing and tongue thrust. By 2.5, he had sleep apnea, he was snoring, he would stop breathing, he was restless and sweating, needed frequent stimulation. And they did a sleep study and thought maybe it was mixed central and obstructive. In other words, a neurological component as well as a physical obstruction component. So he started getting recurrent tonsillitis, so grade 4 tonsillitis, as in tonsils big, pussy, high-grade fevers, antibiotics, bronchiolitis, some more tonsillitis. His sleep apnea got worse, so they did a TNA, tonsillectomy, adenoidectomy, because he was, because of the difficulties of the mouth breathing, I shouldn't say nasal breathing, he wasn't nose breathing, very high palate. After that, he flared again, reflux got worse, he became anemic, and this is, this is when the constipation triggered again. Golly, I do apologise. He needed IV fluids and he was put on some Zofran. That triggered a pattern then, from then on, ongoing severe constipation. From then on, he was Osmolax dependent. His gut failed to work. Oh, golly. Okay. Me and technology. Okay. So then they did an endoscopy. Damaged vocal cords, he had a hiatus hernia. He already had esophageal changes. He's 2.5. So esophageal thickening, he had gastritis, and it looked like, thank you, that he was actually getting bile refluxing up into his stomach because there were changes in the stomach as well. So proven iron deficiency, and they did find that he's one of these ones who would metabolise some proton pump inhibitors faster than others, hence the change from low-sec to SOMAC. By 3, he was getting recurrent falls and clumsiness. After his next vaccine, the parents stated that he had behavioural change, he had anxiety, he was more naughty, he was more willful, he had more infections. So when I got to see him at the age of 4, so I picked him up at 4, he was huge. He was the average size of an 8-year-old. He had weight of 30 kilos at the age of 4. Huge child. He had abdominal obesity. On his medical testing, his thyroid function was off. He had metabolic acidosis. He had high cholesterol, high insulin levels, insulin resistance. He already had fatty liver. 4. He already had fatty liver. A little bit of allergy. But note, allergy was not his major problem, even though he'd been presenting with food problems. It was not his major problem. So what did he have? He had gastroesophageal reflux disease with functional constipation. He had immune dysfunction with recurrent infections, eczema, food allergies. He had endocrine problems with obesity, insulin resistance, metabolic syndrome, and he had neurological issues with developmental delay, sensory dysfunction and behavioural disorder by the age of 4. So what's going on? What's he reflecting? He's not alone in what's going on. He's a dramatic case, but he is not alone. So what happens, what we're seeing, and these are Australian statistics, and this is already out of date, that the health of our children is deteriorating. We've got more and more infectious diseases occurring, otitis media, respiratory tract infections, asthma. What they found was that back in 2001, and as I said, it's getting worse, 58% of all children, more than half, 2/3 nearly, of all children under the age of 5 had been ill in the previous 2 weeks. Not just a few months, the previous 2 weeks. 30% with long-term illness. So we're saying we've got 1/3 of children under the age of 5 who've got long-term illness. This is crazy. In 5 to 14 years, only 30% had been well in the previous 2 weeks. Not 30% had been sick in the previous 2 weeks. Only 30% had been well in the previous 2 weeks. 5 to 14-year-olds. 50% of all children with a long-term illness. UK adolescent studies, we don't have some in Australia. We're saying 20% of young people, your adolescents, long-standing ailments, which has gone up since last measured in 1975. So what we're seeing is very much an underlying immune system dysfunction. So then we look at 2004 to 5, 40% of children under 15 years long-term health problems. Boys more likely than girls. Respiratory problems common. Asthma, hay fever, allergies, chronic sinus, ear infections. So infection does occur mainly in your preschool children. It'll be your commonest reason for hospitalisation during childhood. Certainly low birth weight, lower socioeconomic status will be associated with that, but that's not the only reason. That's not all it is. What are the things causing visits to the doctors? Again, infections, ear infections, asthma, tonsillitis, bronchitis and so on. But then we've got new diseases. So it's not just the old ones, we've got new diseases. And this is just one of them. There are many others I could list here. There's this thing that they now call FAPA. So 1989, that makes it a pretty new disease, okay? In other words, so these are the kids, that you go to the doctor and you say, look, my child keeps having a fever and I don't know why. So they've given it a fancy name now, not because they know the cause, they don't. All this disease name means periodic fever with aphthous stomatitis, pharyngitis and cervical adenitis sounds really fancy. All it means is this kid's getting lots of fevers, they've got mouth ulcers, they've got sore throats and their glands are up, but we've got absolutely no idea why or what to do about it. So it often gets diagnosed as tonsillitis. But in these kids, there often is a history of recurrent ear infections, tonsillitis, sinusitis, antibiotics. And they might take the tonsils out, but they typically relapse. New diseases, so otitis media, now the most common infectious disease in young kids. 80% in USA figures, and these are already old, 80% of all children by the age of 3. Incidence varies across your countries. Different countries have more of this, but it is the most common reason for antibiotic prescribing in the Western world, and that includes here. And so 50%. Acute infections before 6 months, USA, and our figures are pretty much the same as USA, 50% of all kids before the age of 6 months already ear infections. Current figures are showing it's about 90% of all kids by 2 years. And if it occurs early, it does have prolonged effects. Breastfeeding is protective, but our big problem with breastfeeding is that in our society, the official recommendation is that all children should be breastfed to 6 months. That's the official World Health Organisation recommendation, and longer than that if possible. So 67% breastfed at 3 months, but by the time we get to 4 to 6 months, only 50%. So we're nowhere near the WHO recommendation. So here's your ear, and this is what's happening with otitis media. This is our normal. There we go. There's our normal ear. So here's your eustachian tube that drains the ear. But what happens when we get acute virus or something that's typically tracked up the eustachian tube, this gets inflamed and this swells. So then this doesn't drain out. And that's really when you get the problems. And it looks like that. We get this bulging drum. Okay. And I won't go into the details of describing it, you can look at that later. So, but then if it becomes chronic, you get what's called glue ear. Most of you, no doubt, or a lot of you will have run into glue ear. So glue ear is where that fluid that came from the acute infection can't drain out of the ear, and it becomes a chronic issue. And again, it's becoming more and more common cause of hearing loss in childhood. Usually preceded by an infection. So as I said, normally it's going to resolve, but what's happening with glue ear is it's not resolving, it can become chronic. But having said that, it can resolve spontaneously. Don't go automatically thinking just because your child's got recurrent glue ear that you've got to go and put in grommets. We actually don't know how grommets work. By the age of 6 years, hearing will have normalised in almost all affected children, irrespective of treatment. And there are other issues around grommets. There's use of anaesthetics, and they extrude frequently anyway. So, and that's just showing one of the reasons you can get a blocked eustachian tube. That's a swollen adenoid, which will often happen when you've got recurrent tonsillitis and infections. So we don't know. Standard medicine doesn't know why these kids keep getting these infections and what the glue ear and everything's all about. We really don't know. But the point is, there are all of these factors. So with any infection, there are all of these factors. It's not just about where is it getting in or how is it getting to them, which we're so busy worrying about, will everybody wash their hands and, so on, and maybe we'll block this and block that. But really, and it's, yes, the infectious agent is important. There are some bacteria that are just plain more virulent and tricky than others. But really, the key issue, and even Louis Pasteur on his deathbed pointed this out, he said, really, it's about the environment. It's not so much about the bacteria. So it's really about what's happening in our hosts that has changed this pattern of disease in children and adults for that matter so dramatically over the last 30 years. What's happening in the hosts? Because the bacteria really, yes, we're breeding them to be more resistant, there's no doubt about that, but the bacteria are essentially still the bacteria. Paracetamol. We're all told paracetamol is safe to use with your children. It's available over the counter. You're allowed to use it like lolly water. Please don't. We actually have no evidence that paracetamol or ibuprofen is any better than placebo. It does prolong the duration of the illness, however, and it does carry side effects. Affects the immune system and so on. Brufen should not be used to control fever in children. There are reports coming in on side effects. It's great if you've got it's a drug of first choice for inflammatory pain, like an arthritis type pain, that it should not be being used to control fever. Asthma. Increased risk of asthma if, as infancy, there's been paracetamol and there's been the non-steroidals, there's been Brufen. Okay, increased risk of asthma. Constipation, more and more across the world, varying in your different countries. There's your criteria for functional constipation, which I won't go into, but basically it's about not pooping. And it's becoming really common. Infant reflux, regurgitation is common in infancy, but this too is becoming worse and worse. So we're getting 2/3 of infants at 4 months who are still refluxing, but the problem is we're seeing more of genuine reflux disease, like Oscar had, not just that he's refluxing, but it's to the point where you've got changes on endoscopies. Mental health. 7% of kids less than 15 years have got some form of mental health or behavioural condition, and this was on the ABS 2004 to 2005. I'm not actually going to the figures on ASD, but I'm sure you've heard plenty about that already. That's escalating dramatically, and we're currently looking about 1 in 50. Why is this happening? Fruit and veg, we can see that there's very poor intake. This is Australian figures, 2014-15. We see that most kids will eat fruit. Most of you know this. You can usually get them to have some fruit. But eating veggies is another story altogether. Only 5% of children aged 2 to 18 were meeting guidelines for vegetables. 1 in 20 kids are eating their veg. Overweight, 1/4 overweight or obese already, and that's gone up. Girls are more likely to eat their fruit. Like, what about time on the computer? This is proving a growing issue, especially given now that schools are using them all the time. Children spent an average, this is in 2007, again, that's old data, that's the most recent we can get, an average of 20 hours over a school fortnight in 12 months previous watching TV videos or DVDs. And it's more than that now. Most kids, you'll find, there's a story of, yes, they'll often watch something, they'll often be put in front of the TV in the morning as a baby minder. So they'll often watch in the morning, first thing they come home in the afternoon, they're heading straight to the TV or the computer. Gone are the days where the kids were always playing outside and doing things. We need to institute a rule where while there's daylight, the kids are outside. 8 hours playing electronic or computer games, that was on top of TV videos or DVDs. What about the antibiotics? Lots being used. You can look at the figures later. That just shows your use of antibiotics. You can look at that later. What's interesting, antibiotics have no early effect on pain, right? You're told you need to put this for ear infections to block the pain. It doesn't make a difference. It's not your solution. A modest effect on the number of kids who are going to go on to a perforation, which is another excuse we say we need to do it. A moderate effect on whether they're going to get it in the other side. A moderate effect on whether it's going to make a difference to glue ear. So really, this is official medical Cochrane stuff. You still don't hear it sprouted, but this is the official medical guidelines that you need to treat 1 in every 14 kids. For every 14 kids who are treated, you're going to get adverse events, but should really only be used if you've got a child less than 2 years who've got both ears infected, or you've got an older child who's got an ear infected and there's a rupture and there's discharge. Should not be used for routine ear infections in any age. Needs to be just watched. No evidence that using antibiotics reduces the need for grommets later on, and we have no evidence at this point that it actually is making any difference to things like speech, language, behaviour and so on. Be really careful with these things. What do? The problem with our antibiotics is that they change the ability, they change the pattern of the gut flora, and after recurrent antibiotic use, the gut cannot recover. It's not like it's just a round of probiotics is just going to bring it back for you. What does it mean? Antibios, against life. It's not just bacterial life. What the research is now showing, antibiotics act against the basic cellular machinery in the microorganisms, and yes, it'll have an effect against our good bacteria, but, actually I'll come back to that in a second. Okay, you can look at this later at your leisure, but this really is just a beautiful map showing all the different places that bacteria are in our body and all the different types. So we have more bacteria in us than we have of our own cells by a big factor. So we really need to be mindful of that. And it's now officially being said, this is a College of Pharmacy, a professor of College of Pharmacy. The scientists now suspect that antibiotic use, especially overuse, can have unwanted effects on everything from the immune system to glucose metabolism to food absorption, obesity, stress and behaviour. And we go on. So it depletes the normal microbes, leads to overgrowth of resistance. But this was the point I was coming to, that within our cells we have our own mitochondria, which are thought to be like bacteria. What we now have evidence is that antibiotics are affecting our mitochondria. So it's not just killing the bacteria that we want to kill. Don't kid yourself of that. There is no antibiotic that is so specific that all it does is take out that one bacteria that's causing that particular infection you're going for. It does a lot else as well. So they damage the mitochondria in our cells. Prenatal antibiotics increase the risk of asthma and wheeze. Proton pump inhibitors, which I touched on earlier, which are being used increasingly in kids, will decrease your gut bacterial pattern and cause more wrong problems. So the whole thing about the gut is it's a very complex system. It's not just one. One little probiotic's not going to fix what's going on in the gut. It's a very complex system, which via a lot of nerve interactions, and it's a whole separate lecture I give on the connections between the gut and what's going on in the rest of the body. It's very complex, but there's a lot of crosstalk, and that's just a little summary about some of what they do. So bugs come in. We used to think that the uterine environment was sterile. We now know it's not. The bug is actually getting bacteria in the uterus. These have come across from the mother's gut. And so this shows your tracking of how the bacteria come into the baby across time and how they mature. So you can see there's a big environmental factors around whether they're given antibiotics, whether they're breastfed, what is happening with their own genetic patterning, what else is going on in their environment by way of chemicals, by way of stressors. So the first 12 months are crucial to this whole thing. And it particularly affects the hypothalamic pituitary axis, which is your stress axis. If a lot goes on for a bubby in the beginning that's going to affect their gut bacteria, it is going to affect behaviour because this baby's ability to modulate stress is affected. They cause an immune system shift. This change in bacteria shifts the immune system, so there's going to be more allergy, more asthma, more eczema, depending also then on the family genetics. If you're an atopic family, then the risk for that's going to be much higher. And how that happens, leaky gut. You've probably all heard about leaky gut, but basically the wrong bacteria inside the gut irritate the gut lining, the cells swell and separate, and then wrong bacteria, bacterial toxin, partially digested food, undigested food comes across the gut wall because 70 to 80% of our immune system lines the gut. We then get abnormal immune activation. First 12 months, antibiotics in the first 12 months. This is a really recent study out of New Zealand, and basically they found that antibiotics in the first 12 months are dropping IQ, affecting school function, affecting behaviour function, dropping IQ. So it is measurable. And as I said, a lot of ways this happens. You can come back and look at this later. And this is just a quick little picture that just gives you some of the ideas of how this actually works, all the things that they do. So the microbial gut-brain axis. And there's another picture that sort of shows that. All these interactions that we get between the bacteria affecting the brain, the issues in the brain, and issues in the gut, and the effect. It's a two-way communication between the brain and the gut. So you can look at that again later. So chronic illness, are there long-term effects of chronic illness? And so what we're seeing is that we've got a growing research now. They're looking more into adult chronic diseases and are finding that there is a link with your abnormal gut bacteria and then chronic inflammatory conditions. And chronic inflammation is the main thing that underpins most of the adult degenerative diseases. One study that showed lower function in early adulthood among men who'd been hospitalised with ear infections in childhood. Don't quite know exactly why that was. Was it the bacteria? Was it the antibiotics? Which was it? But nonetheless, the effect is there. And so again, as I said, they're seeing more and more that there is a correlation. Hospitalisation with infection seems to be a marker. So we come to this idea about pathogen burden, because what they're finding in adults with coronary vascular disease is that more and more bacteria can actually be found inside the atherosclerotic plaques. And there are whole concepts, about that, which I'm just not going to go into at all now. But it's not just about one, we're used to this old idea of one specific bacteria, one specific infection. It's not that. It's about total system stuff. About has the body reached the stage where it can't deal with things, and so now we have all these bacteria who are hiding there, and what can the body do with that? Maybe we can wall it off in a bit of plaque, but what can the body do with that? So pathogen burden. So we've got this strong interrelation between early childhood infections, antibiotic use, paracetamol use, gut dysfunction with proton pump inhibitor use, immune dysfunction, and then nervous system and brain dysfunction and disease later in life. It's not irrelevant, it's incredibly important. So back to Oscar. So this was 15 months after his initial consult. He was then 5.5 years old. His cognitive development had been assessed as being normal in fine motor, normal in gross motor. In school, he was a model student. At home, he would sometimes switch. He could sometimes still get angry and aggressive, but it was only 5 or 10 minutes rather than hours. Was sometimes even remorseful. His speech had normalised. His sleep had normalised. His headaches had settled. He'd trimmed down. He'd lost his weight. His bloods had normalised. And he was, sorry, I forgot to put in there, he was also off the Somac. He was off the Osmolax. And I finished in time.